Now, let's begin with high-yield facts in endocrinology. Disorders of glucose metabolism, metabolic syndrome. Metabolic syndrome refers to a constellation of findings suggestive of insulin resistance that often develops in the setting of obesity. The frequently associated hyperinsulinemia, hyperglycemia, and release of adipokines are thought to increase the risk for the development of atherosclerotic cardiovascular disease and type 2 diabetes mellitus. A useful mnemonic is WAIT, which stands for waist expanded, impaired glucose, hypertension, HDL decreased, and triglycerides increased. On history and physical examination, findings may include abdominal obesity, even in the setting of overall normal weight, acanthosis nigricans, and elevated blood pressure. The diagnosis of metabolic syndrome is made when at least 3 of the following 5 criteria are present: abdominal obesity, elevated fasting glucose, hypertension, low HDL cholesterol, and hypertriglyceridemia. The best initial treatment is lifestyle modification. Mitigation of cardiovascular risk is achieved with aggressive cholesterol management, blood pressure control, and initiation of metformin for prevention of diabetes in those with impaired fasting glucose. Diabetes mellitus. Diabetes mellitus refers to abnormal carbohydrate metabolism that results in hyperglycemia through several mechanisms, including impairment of insulin secretion and resistance of peripheral tissues to the action of insulin. The presentation of diabetes is variable, and it depends on the specific etiology. It may often be asymptomatic. Generally, type 1 diabetes mellitus classically presents in children and young adults with symptoms of hyperglycemia, such as polyuria, polydipsia, polyphagia, unexplained weight loss, or diabetic ketoacidosis. Type 2 diabetes mellitus classically presents in older adults with obesity and other components of metabolic syndrome, but it is increasingly being diagnosed in children as well. Other risk factors include positive family history, sedentary lifestyle, increasing age, and ethnicity, such as Asian, Hispanic, and African descent in the United States. Although type 2 diabetes mellitus may present with the same symptoms of hyperglycemia as type 1, its onset is more insidious, and patients frequently present already exhibiting complications of long-term diabetes at the time of diagnosis. Chronic complications of diabetes mellitus. Chronic complications of diabetes mellitus. Retinopathy, non-proliferative, proliferative. Diabetic retinopathy classically appears when diabetes has been present for at least 3 to 5 years. Preventive measures include control of hyperglycemia and hypertension along with annual eye exams. Treatment modalities include antivascular endothelial growth factor, VEGF, agents, and laser photocoagulation therapy. Diabetic nephropathy. This condition is characterized by glomerular hyperfiltration followed by microalbuminuria, macroproteinuria, and eventual progression to chronic kidney disease. The prevalence is estimated to be between 20% and 40% in those with diabetes mellitus. Preventive measures include glycemic control and tight blood pressure control, with the use of angiotensin-converting enzyme inhibitors, ACE inhibitors, or angiotensin receptor blockers, ARBs, in the setting of proteinuria. Kimmel-Steele-Wilson nodules are classically seen on kidney biopsy. Neuropathy. The prevalence of diabetic neuropathy increases with longer duration and worsening severity of hyperglycemia. It can affect both small nerve fibers, leading to problems with pain and temperature sensation, and large nerve fibers, leading to impairment in vibration sense and proprioception. The most common manifestation is distal symmetric polyneuropathy, described as a stocking and glove distribution of numbness, tingling, and burning pain. Autonomic neuropathy may also occur, leading to postural hypotension, gastroparesis, diarrhea, neurogenic bladder, or erectile dysfunction. Cranial mononeuropathies can also occur, with cranial nerve 3 involvement being the most common, presenting with ptosis and diplopia but preserved pupillary response. Preventive foot care is essential. Monofilament testing is useful to predict ulcer risk. Neuropathic pain can be managed with tricyclic antidepressants, serotonin norepinephrine reuptake inhibitors, SNRIs, or gabapentinoids. Gastroparesis with delayed gastric emptying can be managed with metoclopramide or erythromycin. Macrovascular complications. These include cardiovascular, cerebrovascular, and peripheral vascular disease. Cardiovascular disease is the most common cause of death in diabetic patients. Risk modification recommendations are outlined in Table 2.3-2. Hypoglycemia unawareness. This occurs due to an inadequate autonomic response to hypoglycemia caused by insufficient release of stress hormones. It tends to develop in individuals who have frequent episodes of hypoglycemia, and it can lead to a failure to recognize life-threatening hypoglycemia. Microalbuminuria cannot be detected on routine urinalysis, UA, protein dipstick. Instead, do a spot urine albumin to creatinine ratio, where microalbuminuria is defined as 30 to 300 milligrams G. Diagnosis of diabetes requires either a random plasma glucose level greater than or equal to 200 milligrams DL plus symptoms of hyperglycemia, or 2 abnormal results with any of the following tests. A fasting plasma glucose level greater than or equal to 126 milligrams DL after more than 8 hours of fasting. A 2-hour postprandial glucose level greater than or equal to 200 milligrams DL following an oral glucose tolerance test, OGTT, or a hemoglobin A1C, HbA1c, greater than 6.5%. Screening for type 2 diabetes mellitus should be considered in overweight adults with at least one risk factor for diabetes, such as hypertension. Cardiovascular disease, sedentary lifestyle, dyslipidemia, polycystic ovary syndrome, or having a first-degree relative with diabetes. Screening is also recommended for patients planning pregnancy. Patients on medications that increase the risk for diabetes, such as chronic steroids, HIV medications, or antipsychotics, and in all people aged 45 years or older, where HbA1c should be checked. If the HbA1c is less than 5.7, it should be rechecked every 3 years unless other risk factors develop. And if the HbA1c is between 5.7 and 6.4, it should be rechecked yearly. Patients who do not meet the criteria for diabetes, but have impaired fasting glucose greater than 100 but less than 126 milligrams DL, or impaired glucose tolerance on OGTT, should also be rechecked yearly. Type 1 diabetes mellitus is due to destruction of the beta cells of the pancreas, which normally produce insulin. This destruction can be secondary to autoimmune disease, acquired disease, or idiopathic disease. Autoimmune type 1 diabetes is characterized by the presence of autoantibodies such as anti-glutamic acid decarboxylase, anti-IgD, anti-islet cell antibodies, anti-zinc transporter antibodies, or anti-insulin antibodies, and it is associated with human leukocyte antigen, HLA, DR3, and HLA, DR4. Acquired disease may occur after pancreatitis, pancreatectomy, cystic fibrosis, or malignancy. Idiopathic disease occurs in the absence of antibodies or any recognized destructive disease. Type 2 diabetes mellitus is due to relative insulin deficiency in the setting of peripheral insulin resistance, which leads to hyperglycemia. More than 90% of diabetes mellitus cases are classified as type 2, and the antibodies associated with type 1 diabetes will be negative. Other less common etiologies of diabetes include several genetic defects that affect beta cell function. For example, several autosomal monogenetic defects have been identified as causes of maturity-onset diabetes of the young, MODY, which typically presents in young people with a family history of atypical diabetes. Management of diabetes begins with patient education and lifestyle modification, which are the mainstays of therapy. Diabetes mellitus general health maintenance involves several lifestyle modifications and preventive measures. Patients should follow a personalized diet that encourages weight loss and emphasizes avoiding saturated fats and added sugars. Regular physical activity is strongly recommended, specifically moderate intensity exercise for 30 to 60 minutes at least 5 days per week. Cardiovascular risk modification is essential because the presence of diabetes is considered equivalent to the highest risk for cardiovascular disease regardless of other risk factors. Therefore, all diabetic patients between 40 and 75 years of age should be placed on a statin regardless of lipid levels, and the AHA risk calculator should be used to determine whether moderate or high-intensity statin therapy is most appropriate. Blood pressure management is another key component, with strict control recommended to keep blood pressure below 130/80 millimeters of mercury. Angiotensin-converting enzyme inhibitors, ACE inhibitors, or angiotensin receptor blockers, ARBs, are considered first-line agents when proteinuria is present. Screening exams should be performed annually to monitor for complications. This includes cardiovascular disease screening with blood pressure and lipid monitoring, nephropathy screening with testing for microalbuminuria, retinopathy screening through dilated eye exams, and neuropathy screening with emphasis on preventive foot care evaluations. Immunizations are also part of diabetes health maintenance. In addition to routinely recommended vaccines based on age, all patients with diabetes over 19 years of age should receive the pneumonia vaccine. Type 1 diabetes mellitus requires administration of insulin to maintain blood glucose in the normal range, with target levels of 80 to 130 milligrams DL preprandially and less than 180 milligrams DL postprandially. Insulin preparations differ in pharmacokinetics. Short-acting insulins such as Aspart, Lispro, and Glulisine have an onset of 5 to 20 minutes, a peak between 0.5 and 3 hours, and a duration of 3 to 8 hours. Regular insulin has an onset of about 30 minutes, peaks between 2 and 4 hours, and lasts 5 to 8 hours. Neutral protamine hagedorn, or NPH insulin, has an onset of 2 to 4 hours, peaks between 6 and 10 hours, and has a duration of 18 to 28 hours. Long-acting insulins, such as Detamir and Glargine, have an onset of about 2 hours, no significant peak, and a duration of 20 to 24 hours. For patients with type 1 diabetes who have difficulty managing blood glucose with intermittent dosing, the use of an insulin infusion pump may be considered. Type 2 diabetes mellitus can often be managed initially with non-pharmacologic interventions such as diet, exercise, and weight control. For patients with type 1 diabetes who have difficulty managing blood glucose with intermittent dosing, the use of an insulin infusion pump may be considered. Type 2 diabetes mellitus can often be managed initially with non-pharmacologic interventions such as diet, exercise, and weight control. If lifestyle interventions fail, pharmacotherapy is introduced, either as monotherapy or in combination if glycemic control remains poor. Metformin is the first-line therapy. It inhibits hepatic gluconeogenesis and improves peripheral sensitivity to insulin. Adverse effects include gastrointestinal upset and, rarely, lactic acidosis. It should be avoided in patients with renal insufficiency, hepatic failure, or heart failure. Metformin promotes weight loss, reduces cardiovascular disease events, and lowers hemoglobin A1C by approximately 1.5 to 2%. Sulfonylureas such as glipizide, glyburide, and glympyride increase endogenous insulin secretion. The main risks are hypoglycemia and weight gain, and they should be avoided in older patients. They decrease microvascular events and reduce hemoglobin A1C by 1 to 2%. Thiazolidinediones, including rosiglitazone and pioglitazone, increase insulin sensitivity. Adverse effects include weight gain, edema, hepatotoxicity, and bone loss, and they should be avoided in patients with heart failure. They reduce hemoglobin A1C by 0.5 to 1.5%. It is important to note that in September 2010, the U.S. Food and Drug Administration restricted access to rosiglitazone due to concern for increased cardiovascular risks, limiting its use to patients already on the medication who acknowledge the risks and to patients unable to achieve adequate glycemic control with other agents. Dipeptidyl peptidase, for inhibitors such as sitagliptin, linagliptin, and other agents in this class inhibit degradation of glucagon-like peptide 1, thereby increasing insulin secretion and reducing glucagon secretion. Adverse effects include an increased risk of infections and rash. They lower hemoglobin A1C by 0.5 to 1%. Incretins such as exenatide, liraglutide, and other GLP-1 agonists delay gastric emptying, decrease hunger, increase insulin secretion, and decrease glucagon secretion. They are administered subcutaneously. Side effects include nausea, slowed gastrointestinal motility, and increased risk of pancreatitis. Liraglutide in particular has been shown to decrease cardiovascular events and mortality in high-risk patients. These agents reduce hemoglobin A1C by 0.5 to 1%. Sodium glucose transporter 2 inhibitors, such as empagliflozin and other drugs in the gliflozin class, inhibit glucose reabsorption in the proximal renal tubule. Adverse effects include urinary tract infections, vulvovaginal candidiasis, Fournier gangrene, volume depletion, and hypotension. Benefits include weight loss, reduction in cardiovascular events and mortality in high-risk patients, and decreased risk of developing or worsening nephropathy. Alpha-glucosidase inhibitors, such as acarbose and miglatol, decrease intestinal absorption of carbohydrates. Side effects include flatulence, diarrhea, and hypoglycemia. They may decrease cardiovascular events in pre-diabetic patients and reduce hemoglobin A1C by about 0.5 to 0.8%. Finally, insulin can be given alone or in combination with oral agents in type 2 diabetes. The primary adverse effects are weight gain and hypoglycemia, but insulin therapy provides the greatest potential reduction in hemoglobin A1C. All patients on insulin should participate in self-monitoring of blood glucose in order to detect hyperglycemia or hypoglycemia, which can then be corrected with dose modifications. Patients with diabetes mellitus should also be encouraged to undergo routine hemoglobin A1C testing every 3 months. The general goal is to maintain an HbA1c below 7%, although in children a slightly higher target of below 7.5% is acceptable. In older adults and in patients with multiple medical comorbidities, higher blood glucose and HbA1c levels can be tolerated due to the increased risk of hypoglycemia in these populations. Tight glucose control has been shown to reduce the risk of microvascular complications, such as nephropathy and retinopathy, but its effects on macrovascular complications, including stroke and myocardial infarction, as well as on all-cause mortality, remain uncertain. Diabetic ketoacidosis, DKA, and hyperglycemic hyperosmolar syndrome, HHS, are two acute, life-threatening complications of diabetes that are characterized by severe hyperglycemia with associated fluid and electrolyte disturbances. Although they share certain similarities, they differ in patient characteristics, precipitants, clinical presentation, and laboratory findings. DKA is more commonly seen in patients with type 1 diabetes compared with type 2 diabetes, while HHS almost always occurs in patients with type 2 diabetes. Common precipitants for both conditions include infections, trauma, alcohol use, and non-adherence to therapy, but HHS may also be triggered by dietary indiscretion. In terms of symptoms, DKA typically presents with abdominal pain, nausea, vomiting, Kussmaul respirations, mental status changes, and a characteristic fruity or acetone breath odor. HHS, on the other hand, is marked by profound dehydration and mental status changes, which are usually more prominent than in DKA. Laboratory values also distinguish the two. In DKA, blood glucose is usually greater than 250 mg dl. Metabolic acidosis is present with a bicarbonate level less than 18 milliequivalent L. Urine and serum ketones are elevated. The anion gap is increased, and serum osmolality is typically normal. In HHS, blood glucose is often greater than 600 mg dl. There is no significant acidosis, as bicarbonate levels are greater than 18 milliequivalent L. Ketones are absent. The anion gap remains normal, and serum osmolality is markedly elevated above 320 mg/kg. Diabetic ketoacidosis, or DKA, is characterized by an anion gap metabolic acidosis with elevated levels of keto acids in both serum and urine. The blood glucose level in DKA is usually between 250 and 500 mg dl, although in some cases it can be higher. Hyperglycemic hyperosmolar syndrome, or HHS, on the other hand, is characterized by extremely elevated blood glucose levels, frequently above 800 to 1,000 mg dl, along with plasma hyperosmolality. Unlike DKA, HHS generally does not involve keto acid accumulation and therefore does not cause an anion gap acidosis. Management of both diabetic ketoacidosis and hyperglycemic hyperosmolar syndrome is similar. The first step is repletion of intravascular volume with infusion of normal saline, as patients with DKA or HHS are typically very dehydrated due to osmotic diuresis resulting from hyperglycemia. Frequent monitoring of serum electrolytes is essential. Acidosis leads to extracellular shifting of potassium, which may cause potassium levels to appear normal or even elevated on initial labs despite an actual total body potassium deficit. As insulin is infused and the acidosis is corrected, potassium shifts back into the intracellular space, which can lead to frank hypokalemia. Regular insulin should be infused intravenously if serum potassium is greater than 3.3 milliequivalent L. And insulin should be continued until resolution of DKA or HHS. This means until the anion gap closes and ketoacidosis is resolved in DKA or until mental status returns to baseline in HHS. If potassium is less than 3.3 milliequivalent L, insulin should be held and potassium should be infused until serum potassium rises above 3.3 milliequivalent L. If serum glucose falls below 200 mg dl before the resolution of acidosis in DKA or below 250 mg dl in HHS, 5% dextrose should be administered intravenously to prevent the need to stop insulin infusion. Hypoglycemia. Symptomatic hypoglycemia is very rare in people who are not on antihyperglycemic medications, even if the blood sugar is measured at less than 70 mg dl. Further evaluation should only be pursued in patients who exhibit Whipple triad. Symptoms of hypoglycemia, such as tremor, anxiety, sweating, paresthesia, dizziness, weakness, confusion, or loss of consciousness. A low plasma glucose concentration measured with a precise method while symptoms are present, and relief of symptoms after blood glucose is raised. Common causes of hypoglycemia include medication use, accidental or intentional antihyperglycemic drug overdose, critical illness, cortisol insufficiency, insulinoma or non-insulinoma islet cell hypertrophy, and recent gastric bypass surgery leading to dumping syndrome. Diagnosis relies on a careful history to determine the timing of symptoms in relation to meals and medications. In diabetic patients taking anti-hyperglycemic drugs, the medication regimen should be reviewed, and doses should be reduced if persistent hypoglycemia is present. If symptoms occur after prolonged fasting, an observed fast with periodic blood glucose checks may be performed, and once symptoms develop, blood should be drawn for glucose, insulin, C-peptide, and an anti-hyperglycemic drug screen. In patients with post-meal symptoms, especially those with a history of gastric bypass, mixed meal testing, a non-liquid meal followed by observation in labs, can help identify dumping syndrome. C-peptide levels guide the etiology. If C-peptide is elevated, endogenous insulin production is the source, as in insulinoma, islet cell hypertrophy, insulin autoimmune hypoglycemia, or insulin secretagogue use, positive on drug screen. If C-peptide is low, the cause is exogenous insulin administration, either prescribed or taken surreptitiously. Management depends on the underlying cause once identified. Acute or profound hypoglycemia can be life-threatening and is most often due to insulin or insulin secretagogue overdose in diabetic patients. Immediate treatment is rapid administration of oral or intravenous carbohydrates. In patients with altered consciousness who lack for access, glucagon should be given via intramuscular, intranasal, or subcutaneous routes. Clinical case. A 10-year-old boy presents to the emergency department with 2 weeks of polyuria and polydipsia and new-onset lethargy. Physical examination reveals signs of severe dehydration, and laboratory values reveal a blood glucose level of 500 milligrams DL. After being diagnosed with DKA, the patient is started on insulin and non-dextrose containing intravenous fluids. Glucose on recheck is 250 milligrams DL with an anion gap of 19. What is the next best step in management? The next best step is to add 5% dextrose to the IV fluids. In the management of DKA, it is important to start IV fluids and insulin immediately. Initially, the goal is to rehydrate the patient and decrease blood glucose. But as blood glucose reaches 250 to 300 milligrams DL, it is important to add 5% dextrose to decrease the risk for hypoglycemia, as the anion gap acidosis is still being treated. Thyroid disorders, thyroid physiology. Thyroid hormone synthesis and regulation can be understood by looking at the processes within the follicular thyroid cells and the hypothalamic pituitary thyroid axis. Iodide, I, from the bloodstream is taken up by follicular thyroid cells and transported into the colloid of the follicle. There it is oxidized to iodine, I, which then combines with thyroglobulin to form monoityrosine, MIT, and deuterosine, DIT. 2 DIT molecules combine to form T4, while 1 MIT and 1 DIT combine to form T3. The iodinated thyroglobulin is then transported back into the follicular cells, where it is cleaved in lysosomes, releasing T4 and T3 into the circulation. The hypothalamic pituitary thyroid axis regulates thyroid function. Thyrotrophin-releasing hormone, TRH, from the hypothalamus stimulates thyroid-stimulating hormone, TSH, released from the pituitary, which in turn stimulates the thyroid to produce and secrete T4 and T3. Feedback mechanisms are in place, with elevated T3 and T4 levels inhibiting TRH and TSH release. Additional modulators include somatostatin, which suppresses TSH, and thyroid-stimulating immunoglobulins, TSI, which mimic TSH in conditions such as Graves' disease. The best initial screening test for thyroid disease is measurement of thyroid-stimulating hormone, TSH, alone. Whenever there is suspicion of thyroid disease or the presence of a goiter on physical examination, TSH should be checked. If there is a history or suspicion of hypothalamic or pituitary disease, then both TSH and free T4 should be measured initially to provide a more accurate assessment of thyroid function. Total T4 measurement is not adequate for screening, since 99% of circulating T4 is bound to thyroxine-binding globulin, TBG. Changes in TBG levels, which can occur in pregnancy, with estrogen administration, or in infection, can alter total T4 values without reflecting actual thyroid status. In general, thyroid function testing should not be performed during periods of acute illness, as many factors, including medications, decreased binding protein levels, and transient central hypothyroidism, can affect thyroid function test, TFT, results. Thyroid function tests in thyroid disease. First, in primary hyperthyroidism, the story begins with an overactive thyroid gland itself. The thyroid overproduces hormones, leading to elevated T4 and T3 levels. In response, the pituitary gland drastically reduces its output, resulting in a low TSH. Common causes include Graves' disease, toxic multinodular goiter, and certain medications like amiodarone. Conversely, secondary hyperthyroidism is a much rarer scenario. Here, the problem originates in the pituitary gland, which inappropriately overproduces TSH. This drives the thyroid to overwork, leading to high T4 and T3 levels. The key diagnostic clue is that the TSH is normal or even elevated when it should be suppressed, often due to a TSH-producing pituitary adenoma. Moving to underactive conditions, primary hypothyroidism is the most common. The thyroid gland fails, leading to low T4 and T3 levels. With no negative feedback, the pituitary gland releases more and more TSH, resulting in a high TSH reading. This is frequently caused by Hashimoto's thyroiditis, or iatrogenic causes like radioactive ablation or surgery. In secondary hypothyroidism, the issue is again a lack of signal from the pituitary. With low or absent TSH, the thyroid is not stimulated, leading to low T4 and T3 levels. The TSH itself will be low. This is often caused by pituitary tumors, infiltrative diseases, or surgery. A more subtle condition is subclinical hypothyroidism. Here, the patient is generally asymptomatic with normal T4 and T3 levels, but the pituitary gland is showing early signs of concern by secreting a mildly elevated amount of TSH, suggesting the thyroid is struggling to keep up. Finally, we have euthyroid sick syndrome. This is not a primary thyroid disease. Instead, it's a condition seen during any serious systemic illness. The pattern shows low or low normal T3, with normal or low T4 and TSH. The key mechanism is a shift in hormone conversion, where T4 is converted to an inactive form called reverse T3 instead of active T3. This is thought to be a protective adaptation during illness to reduce metabolism, and importantly, thyroid hormone supplementation is not indicated. Hyperthyroidism and thyrotoxicosis. Hyperthyroidism refers to increased production of thyroid hormones, while thyrotoxicosis refers to the clinical state resulting from excess thyroid hormone in the body. The most common cause is Graves' disease, an autoimmune disorder in which TSH receptor stimulating autoantibodies increase the synthesis of T3 and T4. Other causes include toxic adenoma or toxic multinodular goiter, in which hyperthyroidism results from autonomous hyperactive thyroid nodules. Thyroiditis can also cause thyrotoxicosis due to transient inflammation of the thyroid gland, which releases preformed thyroid hormone. This is usually followed by a hypothyroid phase before returning to normal function in many patients. Fetal thyrotoxicosis may occur in infants born to mothers with Graves' disease due to transplacental transfer of IgG-TSH-stimulating antibodies. Key fact: exophthalmos, pretibial myxedema, and thyroid bruits are specific for Graves' disease. History and physical examination. Patients may present with weight loss, heat intolerance, anxiety, palpitations, increased bowel movement frequency, myopathy with proximal muscle weakness, insomnia, and menstrual irregularities. On physical exam, findings may include warm and moist skin, goiter, hypertension, sinus tachycardia, or irregular rhythms such as atrial fibrillation or other tachyarrhythmias, fine tremor, lid lag, and hyperactive reflexes. Exophthalmos due to direct stimulation of orbital fibroblasts by antibodies, pretibial myxedema, acropicy, soft tissue swelling of the hands, and thyroid bruits are features seen primarily in Graves' disease. Untreated long-standing hyperthyroidism can result in decreased bone mass. Diagnosis. The best initial test is measurement of serum TSH, followed by free T4 and T3 levels. Additional information can be obtained from radioactive iodine, RAI, scans, and thyroglobulin levels. A radioactive iodine uptake, RAIU, test and scan measures the degree and distribution of iodine uptake in the thyroid and helps differentiate among the causes of hyperthyroidism. It is especially useful in distinguishing functioning nodules, such as toxic adenomas, which are typically benign, from non-functioning nodules, which require biopsy to evaluate for malignancy. Diagnosis of hyperthyroidism. Radioactive iodine, RAI, uptake and scan, along with thyroglobulin levels, are useful in determining the cause of hyperthyroidism. In Graves' disease, there is increased RAI uptake, and the scan shows diffuse uptake throughout the gland. Thyroglobulin levels are not applicable in this condition. In toxic multinodular goiter, the uptake is normal or increased, and the scan demonstrates multiple nodules with increased activity. Thyroglobulin levels are not typically used here. In toxic adenoma, uptake is also normal or increased, but the scan reveals a single hyperfunctioning nodule with increased uptake. Thyroglobulin measurement is again not needed. In thyroiditis, iodine exposure, or extraglandular thyroid hormone production, the RAI uptake is decreased, the scan shows low activity, and serum thyroglobulin levels are elevated. In cases of exogenous thyroid hormone use, RAI uptake is also decreased with low scan activity, but here the thyroglobulin level is decreased, distinguishing it from thyroiditis. Treatment of hyperthyroidism. Management of hyperthyroidism begins with beta blockade, which is a cornerstone of therapy regardless of the underlying cause. Beta blockers help control the symptoms driven by increased adrenergic tone, such as tachycardia, anxiety, and tremulousness. Antithyroid medications are used to inhibit the oxidation of iodide and thereby impair thyroid hormone synthesis. Methimazole is the preferred first-line agent in most patients. However, during the first trimester of pregnancy, propylthiouracil, PTU, is used instead since methimazole carries teratogenic risk. For definitive treatment, radioactive iodine, I-131, thyroid ablation is generally the therapy of choice. Exceptions include patients with large, obstructive goiters or those with Graves' ophthalmopathy, since radioactive iodine can worsen eye involvement. In such cases, thyroidectomy becomes the alternative definitive option. After ablation or surgical thyroidectomy, patients are placed on levothyroxine, oral T4 replacement, to prevent hypothyroidism and maintain normal thyroid hormone levels. In cases of Graves' ophthalmopathy, especially when it causes diplopia or threatens vision, corticosteroid therapy can be administered to reduce inflammation and preserve function. Adverse reactions and considerations in hyperthyroidism treatment. Methimazole can cause rash, agranulocytosis, and liver dysfunction. It is contraindicated during the first trimester of pregnancy due to its teratogenic risk. Propylthiouracil, PTU, is associated with rash, arthralgias, agranulocytosis, vasculitis, and carries a black box warning for severe liver failure. Despite these risks, is the preferred agent during the first trimester of pregnancy. Radioactive iodine, I-131. Thyroid ablation most commonly results in hypothyroidism as a long-term effect, especially in patients with Graves' disease. It is contraindicated in pregnancy and may initially worsen Graves' ophthalmopathy. Thyroidectomy, the surgical option, carries the risks of postoperative hypothyroidism, hypoparathyroidism, and potential damage to nearby structures such as the recurrent laryngeal nerve. Thyroid storm is an acute, life-threatening form of thyrotoxicosis that may present with tachyarrhythmia, fever, and delirium. It can be precipitated by acute illness, iodine load, or surgery. Treatment of thyroid storm consists of the same measures used in hyperthyroidism, but given rapidly and in a specific sequence. Begin with beta blockade to control adrenergic symptoms, followed by administration of antithyroid medication, with propylthiouracil, PTU, preferred in this case because it also inhibits the peripheral conversion of T4 to T3. Glucocorticoids are then administered to reduce inflammation and further block conversion of T4 to T3. After antithyroid medication has been given, inorganic iodide, such as potassium iodide, can be used to block the release and synthesis of thyroid hormone. Bile acid sequestrants such as cholestyramine may also be helpful, since thyroid hormone is excreted in the bile and can otherwise be reabsorbed in the intestine. Hypothyroidism. Hypothyroidism is most commonly caused by Hashimoto thyroiditis, but it can also result from a variety of other causes. Hashimoto thyroiditis, or autoimmune hypothyroidism, is associated with positive antithyroglobulin and antithyroid peroxidase, anti-DPO, antibodies that lead to thyroid destruction. Patients with Hashimoto thyroiditis also have an increased risk of developing thyroid lymphoma. Other causes include thyroiditis, such as postpartum, post-viral, or subacute de Quervain thyroiditis, which can progress through a hypothyroid phase following an initial hyperthyroid phase. Secondary hypothyroidism may occur due to pituitary tumors or pituitary surgery. Congenital hypothyroidism is most commonly caused by thyroid dysgenesis. Rarely, generalized resistance to thyroid hormone may occur, characterized by elevated T3 and T4 with normal to elevated TSH levels. History and physical examination. Hypothyroidism classically presents with weakness, fatigue, cold intolerance, constipation, weight gain, depression, hair loss, menstrual irregularities, and myopathy. On physical examination, patients often have dry, cold, puffy skin with edema, bradycardia, and delayed relaxation of deep tendon reflexes. Congenital hypothyroidism has characteristic findings remembered by the 6PS: pot belly with a protruding umbilicus, pale, puffy-faced, protuberant tongue, and poor brain development. Other features include jaundice due to unconjugated hyperbilirubinemia and enlarged fontanelles. Signs of congenital hypothyroidism typically appear in the first few months of life because maternal T4 crosses the placenta, providing adequate hormone levels at birth before they decline. Diagnosis. The best initial test for hypothyroidism is a serum TSH level, followed by free T4 levels. Other common laboratory abnormalities include elevated LDL cholesterol, increased triglycerides, increased creatine kinase, CK, and hyponatremia. Treatment. For frank hypothyroidism, treatment is with levothyroxine. In subclinical hypothyroidism, defined as elevated TSH with normal T4, levothyroxine is indicated if the TSH is greater than 10 mL. Myxedema coma. Myxedema is a severe, life-threatening form of hypothyroidism that presents with decreased mental status, hypothermia, hypotension, bradycardia, hypoglycemia, and hypoventilation. The mortality rate is 30% to 60%. It can be triggered in a hypothyroid patient by acute events such as infection, myocardial infarction, stroke, trauma, sedative drugs, surgery, or medication non-adherence. Treatment requires admission to the intensive care unit and urgent administration of intravenous levothyroxine and intravenous hydrocortisone, unless adrenal insufficiency has already been excluded. Thyroiditis. Thyroiditis refers to inflammation of the thyroid gland. Common subtypes include subacute granulomatous thyroiditis, radiation-induced thyroiditis, autoimmune thyroiditis, postpartum thyroiditis, infectious thyroiditis, and drug-induced thyroiditis, such as that caused by amiodarone. History and physical examination. The subacute form typically presents with a tender thyroid, usually following an upper respiratory tract infection. All other forms are generally associated with a painless goiter. Diagnosis. Thyroiditis is associated with thyroid dysfunction, most commonly an initial hyperthyroid phase that progresses to hypothyroidism. During the hyperthyroid phase, radioactive iodine, RAI, uptake is decreased on scan. Treatment. Subacute thyroiditis is usually self-limited. Management includes nonsteroidal anti-inflammatory drugs, NSAIDs, or oral prednisone for pain relief. Beta blockers are appropriate to control symptoms of hyperthyroidism. Antithyroid medications are generally not indicated. Levothyroxine is appropriate for treating hypothyroidism associated with thyroiditis if TSH is greater than 10 ml. Clinical case. A 24-year-old woman with hypothyroidism presents at 10 weeks gestation for a prenatal visit. Her only medication is levothyroxine. What adjustment is probably needed to her levothyroxine dose? The patient's dose will probably have to be increased, sometimes by up to 50%. Increased thyroxine binding globulin levels in pregnancy leads to decreased free T3, T4 levels and increased TSH. Thyroid neoplasms. Thyroid nodules are very common and show an increased incidence with age. Most, about 95%, are benign. History and physical examination. Thyroid nodules are usually asymptomatic on initial presentation and are often discovered incidentally. Hyperfunctioning nodules may present with symptoms of hyperthyroidism. Large nodules adjacent to the trachea or esophagus may cause compressive symptoms such as dysphagia, dyspnea, cough, or a choking sensation. An increased risk for malignancy is associated with a history of childhood neck irradiation. The presence of cold nodules with minimal uptake on a radioactive iodine scan. Female sex. Age younger than 20 or older than 70. Firm and fixed solitary nodules. A positive family history. And rapidly growing nodules that present with hoarseness. Hyperfunctioning, hot. Nodules are typically benign. Diagnosis and management. When a thyroid nodule is found, either clinically or incidentally on imaging, the first step is clinical evaluation along with measurement of TSH and an ultrasound of the neck. If the TSH is suppressed, the next step is to perform a thyroid scintigraphy. If the scintigraphy shows a hyperfunctional or hot nodule, the management is either radioiodine ablation or surgical excision. If the nodule is hypofunctional, cold, or indeterminate, further evaluation is required. If the TSH is normal or elevated, then the next step is to assess whether the nodule meets sonographic criteria for fine needle aspiration, FNA. These criteria are based on the presence of risk factors for malignancy or suspicious ultrasound findings. If the criteria are met, FNA is performed. If the FNA results are malignant, the appropriate management is thyroid surgery. If the FNA results are benign, the nodule is monitored with close follow-up. If the nodule does not meet sonographic criteria for FNA, the management is simple monitoring. Benign nodules are usually monitored through physical examination and ultrasonography to assess for continued growth or for the development of suspicious characteristics, such as microcalcifications, increased vascular flow, or nodules that are taller than they are wide. Malignant nodules are best managed with surgical resection, typically hemothyroidectomy or total thyroidectomy. For some high-risk patients, adjunctive radioiodine ablation following surgery is also appropriate to reduce recurrence and treat residual disease. Indeterminate fine needle aspiration, FNA, results present a management challenge, as there is approximately a 10% to 30% chance of malignancy. Initial management options include either watchful waiting with close monitoring or surgical resection with hemothyroidectomy. If surgery is performed, the final pathology report will guide the need for further treatment. Table 2.3 to 8 summarizes the types of thyroid malignancy that can be diagnosed after biopsy. Papillary carcinoma is the most common type of thyroid cancer, representing about 75% to 80% of all cases. It is more common in females, with a female-to-male ratio of 3:1, and the peak incidence occurs between the ages of 30 and 50. It is a slow-growing cancer derived from thyroid hormone, producing follicular cells. Classic histological findings include psammoma bodies, which are round microscopic calcifications, and large optically clear nuclei often described as orphan Annie nuclei. Papillary carcinoma typically spreads via the lymphatic system. The prognosis is generally excellent, with about 90% of patients surviving at least 10 years after diagnosis. However, prognosis is less favorable in patients older than 45 years or in those with large tumors. Follicular carcinoma accounts for about 17% of thyroid cancers and is also more common in females, with the peak incidence between 40 and 60 years of age. Like papillary carcinoma, it is derived from thyroid hormone, producing follicular cells. However, unlike papillary carcinoma, it tends to spread hematogenously, meaning through the bloodstream, and therefore often results in distant metastases. The prognosis is similar to papillary carcinoma, with long-term survival generally good if detected early. Medullary carcinoma represents about 6% to 8% of thyroid cancers. It is derived from parafollicular C cells, which produce calcitonin, so many patients present with elevated calcitonin levels. Medullary carcinoma is strongly associated with multiple endocrine neoplasia type 2, MEN2, a hereditary syndrome. The prognosis depends on age and stage of diagnosis, as well as the degree of vascular invasion. About 80% of patients survive at least 10 years following surgery if detected early. Anaplastic carcinoma is the rarest form, accounting for less than 2% of thyroid cancers. It is highly aggressive, rapidly enlarges, and metastasizes early. The prognosis is very poor, with only about 10% of patients surviving more than 3 years after diagnosis. It is also important to note that some thyroid tumors may contain mixed papillary and follicular histological patterns. Bone and mineral disorders. Calcium and phosphate regulation. The system is triggered when blood calcium levels fall, phosphate levels rise, or active vitamin D levels are low. This stimulates the parathyroid glands to release parathyroid hormone, or PTH, into the bloodstream. PTH then acts on two main target organs, the kidneys and the bones. In the kidneys, PTH has 3 critical jobs. First, it increases the reabsorption of calcium back into the blood. Second, it decreases the reabsorption of phosphate, causing more of it to be excreted in the urine. And third, It activates vitamin D by converting it into its active form, calcitriol. Simultaneously, PTH acts on the bones, causing the release of both calcium and phosphate from the bone matrix into the blood. Now, the active vitamin D produced by the kidneys takes over. It travels to the intestines and dramatically increases the absorption of both calcium and phosphate from your diet. The end result of this entire process is that blood calcium levels are successfully raised back to normal. Finally, this restored normalcy creates a negative feedback loop. The now elevated levels of calcium and active vitamin D directly inhibit further PTH synthesis and release, shutting off the system until it is needed again. Osteoporosis is a common metabolic bone disease characterized by low bone mass. It most often affects thin postmenopausal females, especially those of white or Asian ethnicity or descent, with risk doubling after 65 years of age. Males are also at risk for osteoporosis, but the diagnosis is often overlooked. Key fact: do not confuse osteoporosis with osteomalacia, a mineralization defect often caused by a severe vitamin D deficiency that presents with bone pain, decreased calcium phosphate, and secondary hyperparathyroidism. Osteoporosis is commonly asymptomatic even in the presence of a vertebral fracture. Risk factors include smoking, advancing age, excessive alcohol intake, a history of estrogen-depleting conditions in women, such as amenorrhea, eating disorders, early menopause, or hypogonadism in men, physical inactivity, uncontrolled hyperthyroidism, hyperparathyroidism, chronic inflammatory disease, corticosteroid use, and Cushing syndrome. Examination may reveal hip fractures, vertebral compression fractures with loss of height and progressive thoracic kyphosis, and or distal radius fractures, Cole's fracture, following minimal trauma. The diagnostic test of choice is dual-energy X-ray absorptiometry, DEXA, scan, which is the recommended screening test for all women older than 65 years, men older than 70 years, and those with other risk factors for osteoporosis. Osteoporosis is defined as a bone mineral density, T-score, 2.5 standard deviations below normal, while osteopenia is defined as a T-score between 1 and 2.5 SDs below normal. Laboratory tests help identify secondary causes through measurements of calcium, phosphate, parathyroid hormone, TSH, free T4, liver enzymes, creatinine, and electrolytes. If estrogen deficiency or hypogonadism is suspected, additional labs should include follicle-stimulating hormone, luteinizing hormone, estradiol, and testosterone. Key fact: osteoporosis is the most common cause of pathologic fractures in women with low body weight and in men older than 60 years of age. Treatment includes lifestyle modifications such as adequate calcium and vitamin D intake, smoking cessation, avoidance of heavy alcohol use, and regular weight-bearing exercise. The best initial pharmacologic treatment is bisphosphonates such as alendronate, risedronate, ibandronate, or zoledronic acid. Treatment is also recommended for individuals with osteopenia who have a high calculated osteoporotic fracture risk based on the FRAX calculator. Other medications include teriparatide, a parathyroid hormone analog, denosumab, a monoclonal antibody to RANK-L, and selective estrogen receptor modulators such as raloxifene. The most serious complication of osteoporosis is hip fracture, which carries a 50% increased mortality risk in the year following the fracture. Key fact: upper gastrointestinal side effects such as reflux, esophagitis, and esophageal ulcers are common reasons for intolerance to oral bisphosphonates such as alendronate and risedronate. Paget disease of bone is characterized by an increased rate of bone turnover with both excessive resorption and formation of bone. It is suspected to be caused by the effects of latent viral infection in genetically susceptible individuals and is associated with primary hyperparathyroidism and an increased risk for osteosarcoma. The disease can affect one bone, monostotic, or multiple bones, polyostotic, with the skull, vertebral bodies, pelvis, and long bones most commonly affected. Key fact: increased serum alkaline phosphatase with normal gamma-glutamyl transpeptidase, GGT, points to bone etiology, not liver etiology, as the cause of elevation. Paget disease is usually asymptomatic but may present with aching bone or joint pain, bony deformities, fractures at a pagetoid site, nerve entrapment, headaches, and hearing loss, especially when the skull is involved. Mnemonic: symptoms and signs of Paget disease of bone can be remembered by panics, pain, arthralgia, nerve compression, neural deafness, increased bone density, cardiac failure, skull involvement, sclerotic vertebra. The best initial diagnostic test is plain film X-rays, which usually show lytic and sclerotic lesions. Radionuclide bone scan is necessary to characterize the extent and sites of disease. Laboratory values reveal increased serum alkaline phosphatase with normal calcium and phosphate levels, which must be distinguished from metastatic bone disease. Most patients are asymptomatic and require no treatment. There is no curative therapy, but the goal is to reduce pain and slow disease progression. Pharmacologic treatment includes bisphosphonates as first-line therapy, calcitonin for patients intolerant to bisphosphonates, calcium and vitamin D supplementation, and analgesics such as NSAIDs and acetaminophen. Adjunctive therapy may involve physiotherapy and occupational therapy. Surgery may be required in cases of fractures, severe deformities, or osteoarthritis. Complications include osteoarthritis, pathologic fractures, high-output cardiac failure due to arteriovenous connections, and osteosarcoma in up to 1% of patients. Key fact: bone pain and hearing loss should make you think of Paget disease. Hyperparathyroidism is a condition related to abnormal regulation of calcium and phosphate due to altered parathyroid hormone activity. Primary hyperparathyroidism is most often caused by a single hyperfunctioning adenoma in about 80% of cases, with the rest due to parathyroid hyperplasia in 15% or rarely parathyroid carcinoma in about 5%. Secondary hyperparathyroidism is a physiologic increase of PTH in response to renal insufficiency, which leads to decreased production of 1,2,5-dihydroxyvitamin D, calcium deficiency, or vitamin D deficiency. Tertiary hyperparathyroidism is seen in patients on dialysis with long-standing secondary hyperparathyroidism, which leads to hyperplasia of the parathyroid glands, and when one or more of the glands become autonomous, tertiary hyperparathyroidism results. Pseudohyperthyroidism is due to PTH resistance, where PTH levels are elevated but ineffective at target organs, resulting in hypocalcemia and hyperphosphatemia, and it is associated with Albright hereditary osteodystrophy, which may present with shortened fourth and fifth metatarsal or metacarpal bones. Most cases of primary hyperparathyroidism are asymptomatic but may show signs and symptoms of hypercalcemia. Hypercalcemia is classically associated with the phrase stones, bones, moans, groans, and psychiatric overtones. The best initial treatment of acute hypercalcemia is intravenous fluids and calcitonin, and if it is secondary to malignancy, bisphosphonates should be added. Laboratory findings in primary hyperparathyroidism show hypercalcemia, hypophosphatemia, and hypercalciuria with an inappropriately elevated PTH level relative to serum calcium. In secondary hyperparathyroidism, PTH is elevated, calcium is normal or decreased, and phosphate is elevated when the etiology is renal failure. In tertiary hyperparathyroidism, both PTH and calcium are elevated along with phosphate. In ectopic PT-CHRP production, PTH is suppressed, calcium is elevated, and phosphate is either normal or decreased. PTH-related peptide acts on the same receptors as PTH, and some tumors such as breast and lung cancers can produce PTHRP, leading to hypercalcemia of malignancy. A 99 MTC sestamibi scanned together with thyroid ultrasonography can help localize a solitary adenoma. DEXA scan may reveal low bone mineral density or osteoporosis in the distal radius or other sites. Renal imaging can be used to assess for nephrocalcinosis and nephrolithiasis. Etiologies of hypoparathyroidism include iatrogenic causes such as post-surgical removal, autoimmune disease, congenital conditions such as DiGeorge syndrome, and infiltrative diseases such as hemochromatosis and Wilson disease. For acute hypercalcemia, the best initial treatment remains IV fluids and calcitonin, while intravenous bisphosphonates are suitable for long-term management. Parathyroidectomy is indicated if the patient is symptomatic or meets certain criteria, such as very high calcium, elevated creatinine, low bone mineral density, or age younger than 50 years. In the case of solitary adenoma, one gland is removed, whereas in hyperplasia, 3.5 glands must be excised. In chronic kidney disease, oral phosphate binders, such as calcium salts, sevelamer hydrochloride, or lanthanum carbonate, together with dietary phosphate restriction, help prevent secondary hyperparathyroidism. Cinacalcet, a calcimimetic that lowers serum PTH levels, is approved for use in renal failure, related hyperparathyroidism, or in patients unable to undergo surgery. The most severe complication of primary hyperparathyroidism is hypercalcemia. After parathyroidectomy, patients should be monitored for hungry bone syndrome, which is severe and prolonged hypocalcemia caused by acute reversal of PTH effects and increased uptake of calcium, phosphate, and magnesium into bone. Hyperparathyroidism can also result from ectopic PTHRP production, especially from carcinomas of the breast, lung, and head and neck. Pituitary and hypothalamic disorders are understood through the hypothalamic-pituitary axis, in which the hypothalamus secretes hormones such as corticotropin-releasing hormone, thyrotrophin-releasing hormone, gonadotropin-releasing hormone, growth hormone-releasing hormone, and dopamine, which in turn regulate the anterior pituitary to release adrenocorticotropic hormone, thyroid-stimulating hormone, follicle-stimulating hormone, luteinizing hormone, growth hormone, and prolactin. The posterior pituitary releases antidiuretic hormone and oxytocin. Disorders of this axis can result in deficiency of pituitary hormones. Hypopituitarism refers to deficiency of anterior pituitary hormones, and when posterior pituitary hormones are also affected, the condition is called panhypopituitarism. Common causes include damage to the pituitary gland or hypothalamus from surgery, radiation, or mass lesions such as non-functioning pituitary adenoma or craniopharyngioma. Other causes include Sheehan syndrome, which is pituitary infarction due to severe hemorrhage classically occurring in postpartum women, pituitary apoplexy caused by hemorrhage, infiltrative disorders such as hemochromatosis, and infections. Gonadotropins and growth hormone are often the first hormones to be affected, which leads to growth retardation in children and hypogonadism in adults. Other possible hormone deficiencies include adrenocorticotropic hormone deficiency, secondary hypothyroidism due to lack of thyroid-stimulating hormone, growth hormone deficiency, gonadotropin deficiency, central diabetes insipidus due to lack of antidiuretic hormone, and prolactin deficiency. Clinical features of pituitary hormone deficiencies may develop suddenly, as an apoplexy or Sheehan syndrome, or gradually, as in cases of radiation damage or infiltrative disease. Pituitary hormone deficiencies. Deficiency of ACTH presents with weakness, hypotension, hyponatremia, hypoglycemia, and weight loss. Diagnosis involves measuring morning cortisol levels. If less than 3 micrograms DL, adrenal insufficiency is likely and should be confirmed with ACTH measurement. If between 3 and 18 micrograms DL, an ACTH stimulation test should be performed, and if greater than 18 micrograms DL, adrenal insufficiency is unlikely. Secondary adrenal insufficiency presents with predominant cortisol deficiency, since aldosterone is regulated by the renin-angiotensin system rather than ACTH. Unlike primary adrenal insufficiency, there is no hyperpigmentation. Deficiency of TSH presents with cold intolerance, lethargy, constipation, dry skin, delayed relaxation of deep tendon reflexes, and weight gain. Diagnosis is made with free T4 levels since TSH is not diagnostic. This is secondary hypothyroidism. It is important to rule out ACTH deficiency before starting hormone replacement, because levothyroxine increases cortisol clearance and can precipitate adrenal crisis. Deficiency of growth hormone in children leads to short stature, while in adults it causes decreased bone density, muscle atrophy, increased fat mass, and dyslipidemia. Deficiency of other pituitary hormones is also suggestive. Diagnosis involves measurement of insulin-like growth factor 1, IGF-1, and performing a GH stimulation test. Deficiency of FSH and LH presents in females with primary or secondary amenorrhea and infertility, and in males with decreased energy, decreased libido, infertility, loss of male pattern hair, gynecomastia, and testicular atrophy. Diagnosis involves measurement of LH, FSH, testosterone, and estrogen levels. This is hypogonadotropic hypogonadism. In males, measurement of serum prolactin levels can help rule out hypogonadism secondary to a prolactinoma. Deficiency of ADH presents with polyuria and polydipsia. Diagnosis requires checking urine osmolality and plasma osmolality, and if abnormal, a water deprivation test should be performed. This confirms central diabetes insipidus. Deficiency of prolactin presents with failure to lactate after delivery. Diagnosis is made with serum prolactin levels. This deficiency usually occurs along with other pituitary hormone deficiencies. Diagnosis of hypopituitarism is made by routine testing, which includes measurement of 8 AM cortisol levels on at least 2 separate occasions. Free T4 levels, since TSH alone is not diagnostic, testosterone or estradiol levels, and urine and plasma osmolality. Once a pituitary hormone deficiency is confirmed, a brain MRI should be performed to evaluate for possible underlying causes. Treatment consists of hormone replacement therapy along with management of the underlying disorder, and the specific treatment approach depends on which hormone deficiencies are present. A key fact to remember is that in patients with suspected diabetes insipidus, serum or urinary glucose should be checked to rule out diabetes mellitus. Medical case. An asymptomatic 36-year-old man presents for his annual physical. Routine labs reveal a serum calcium level of 11.3 milligrams DL. He returns in 2 weeks, and his serum calcium level remains elevated. Additional studies show a normal serum PTH level and a low 24-hour urinary calcium level. What is the most likely diagnosis? The patient most likely has familial hypocalciuric hypercalcemia, FHH, an inherited disorder caused by mutations in a calcium-sensing receptor present in the parathyroid and kidney, which presents with elevated serum calcium levels. Unlike patients with primary hyperparathyroidism, these patients are asymptomatic and have low urinary calcium levels. No treatment is required. Diabetes insipidus is the inability to produce concentrated urine as a result of antidiuretic hormone, ADH, dysfunction, leading to free water loss from the kidneys. There are 2 main subtypes. Central diabetes insipidus occurs when the posterior pituitary gland fails to secrete ADH. Causes include tumors, ischemia, such as in Sheehan syndrome, pituitary hemorrhage, traumatic brain injury, infection, metastatic disease, and autoimmune disorders. Nephrogenic diabetes insipidus occurs when the kidneys fail to respond to circulating ADH. This is usually due to renal disease or drugs such as lithium and dimethylcycline. In central DI, ADH is not secreted from the posterior hypothalamus, whereas in nephrogenic DI, ADH is secreted normally, but its end-organ effects on the kidney are blocked. Both central and nephrogenic DI result in excessive free water diuresis and an increase in plasma osmolarity. Diabetes insipidus presents with polydipsia, polyuria, and persistent thirst with dilute urine. If access to water is limited, as in institutionalized patients or older adults, patients may develop dehydration and severe hypernatremia, which can cause altered mental status, lethargy, seizures, and coma. Diagnosis involves laboratory testing that typically shows serum osmolality greater than urine osmolality, decreased urinary sodium, and possible hypernatremia. The water deprivation test is used for further evaluation. In psychogenic polydipsia and in normal renal physiology, water restriction results in concentrated urine. In both central and nephrogenic diabetes insipidus, patients continue to excrete a high volume of inappropriately dilute urine despite water restriction. Water deprivation test. In central diabetes insipidus, serum sodium is usually high. With water deprivation, urine osmolality shows only a mild rise or no significant change. After administration of desmopressin, urine osmolality increases significantly, indicating a response. In nephrogenic diabetes insipidus, serum sodium is also high. With water deprivation, urine osmolality again shows only a mild rise or no significant change. However, after administration of desmopressin, there is no response because the kidneys are resistant to ADH. In primary polydipsia, serum sodium is typically low or normal. With water deprivation, urine osmolality rises to more than 600 mg/kg, which indicates the ability to concentrate urine normally. Administration of desmopressin shows no additional response because ADH secretion and renal response are already intact. Desmopressin acetate replacement test, also known as vasopressin, a synthetic analog of ADH, is used to differentiate between central and nephrogenic diabetes insipidus. In central DI, administration of desmopressin leads to decreased urine output and an increase in urine osmolarity by 50%, 100%. In nephrogenic DI, there is no effect on urine output or urine osmolarity. MRI may reveal a pituitary or hypothalamic mass in cases of central DI. Treatment involves management of the underlying cause. In central DI, treatment consists of administering desmopressin, which can be given intravenously, intranasally, or orally. In nephrogenic DI, treatment includes dietary and pharmacologic measures such as salt restriction, hydrochlorothiazide, amiloride, and a low-protein diet in adults. Clinical case. A 23-year-old man with a history of schizophrenia presents with complaints of fatigue, weakness, cramps, and headache for the past several days. He denies any other symptoms, although he had to urinate several times while in the office. Routine labs reveal hyponatremia. With water deprivation, his urine osmolality increased. What is the most likely diagnosis? The most likely diagnosis is primary, psychogenic polydipsia, a condition in which patients consume large volumes of hypotonic fluid, resulting in polyuria. It most often occurs in patients with psychiatric disorders. Patients present with symptoms similar to DI, but following a water deprivation test, urine osmolality increased versus DI, in which urine remains dilute. Excess of pituitary hormones, acromegaly. Acromegaly is caused by elevated GH levels in adults, most commonly due to a benign pituitary GH-secreting adenoma. In children, excess GH production presents as gigantism. Sleep, hypoglycemia, stress, puberty, and exercise stimulate GHRH release, which increases growth hormone secretion from the anterior pituitary. In contrast, aging, obesity, and hyperglycemia stimulate somatostatin release, which inhibits growth hormone. Growth hormone acts on tissues to increase amino acid uptake, protein synthesis, DNA and RNA synthesis, chondroitin sulfate and collagen production, as well as cell size and number. Through the action of IGF-1, growth hormone further stimulates amino acid uptake, protein synthesis, glucose uptake, and lipolysis. Pituitary adenomas may cause headache, cranial nerve defects, and bitemporal hemianopsia due to compression of the optic chiasm. Systemic manifestations include increased skeletal and soft tissue growth with enlargement of the skull, frontal bossing, wide-spaced teeth, enlargement of the hands and feet, malocclusion of the jaw, coarsening of facial features, and carpal tunnel syndrome. Degeneration of cartilage resembling osteoarthritis may occur, along with skin thickening, skin tags, hyperhidrosis, and organomegaly, such as tongue enlargement. Acromegaly is associated with increased risk of obstructive sleep apnea. Cardiovascular abnormalities including hypertension, left ventricular hypertrophy, and cardiomyopathy with diastolic dysfunction, which is the most common cause of death, type 2 diabetes mellitus, diverticulosis, and colon cancer. Diagnosis relies on laboratory testing. Levels of IGF-1 are elevated in acromegaly, and the diagnosis can be confirmed with an oral glucose suppression test, where GH levels remain elevated despite glucose administration. Baseline GH levels are not reliable because GH secretion fluctuates widely throughout the day. Clinical suspicion of acromegaly arises with findings such as enlargement of the nose, frontal bones, and jaw. The first step is to check IGF-1 levels. If IGF-1 is normal, acromegaly is ruled out. If IGF-1 is elevated, the next step is an oral glucose suppression test. Adequate suppression of GH rules out acromegaly, while inadequate suppression confirms the diagnosis. If GH suppression is inadequate, proceed with MRI of the brain. If a pituitary mass is identified, management involves surgical or medical therapy. If no pituitary mass is seen, evaluate for extrapituitary causes of acromegaly, such as ectopic GHRH secreting tumors. Imaging with MRI typically shows a sellar lesion. Treatment is aimed at reducing GH secretion and controlling tumor mass. The first-line treatment is transsphenoidal surgical resection of the pituitary adenoma. Medical therapy includes somatostatin analogs, such as octreotide or lanreotide, which suppress GH secretion, and pegvisomant, a GH receptor antagonist that blocks peripheral GH actions. Radiation therapy may be considered when surgical and medical therapies fail. Key fact: measurement of IGF-1 levels, not GH levels, confirms acromegaly. Hyperprolactinemia refers to elevated prolactin levels, most commonly caused by a pituitary adenoma. Prolactinoma is the most common functioning pituitary tumor. Other causes include physiologic ones, such as pregnancy and lactation. Pituitary stalk compression from other masses, such as craniopharyngioma, meningioma, and non-secreting pituitary tumors. Hypothalamic dysfunction, medications such as dopamine antagonists and selective serotonin reuptake inhibitors, SSRIs, and systemic conditions such as renal failure, cirrhosis, and hypothyroidism. Prolactin, which drives milk production, is primarily regulated by inhibition. The hypothalamus constantly releases dopamine to suppress its release from the anterior pituitary. This brake is lifted by specific stimuli: nipple stimulation from a breastfeeding baby, the sight or cry of the baby, chest wall injury, high estrogen levels during pregnancy, or high TRH in primary hypothyroidism. When prolactin is high, it not only enables lactation but also suppresses the gonadal axis, GnRH, which inhibits ovulation and spermatogenesis. Elevated prolactin inhibits GnRH secretion and consequently lowers LH and FSH secretion, manifesting as infertility, galactorrhea, gynecomastia, impotence, and amenorrhea. Bitemporal hemianopsia may also be present. Rule out pregnancy in all cases of hyperprolactinemia. Diagnosis is confirmed with a serum prolactin level that is typically greater than 200 ml, along with a pregnancy test to exclude pregnancy. MRI shows a sellar lesion. The best initial treatment is with dopamine agonists such as cabergoline or bromocriptine. Transsphenoidal surgery is indicated in adenomas refractory to medical management or with compressive effects such as visual loss. Radiation is rarely indicated. Syndrome of inappropriate antidiuretic hormone secretion, SIAD, is a common cause of euvolemic hyponatremia that results from persistent ADH release independent of serum osmolality. It may be associated with central nervous system disease, such as head injury or tumor. Pulmonary disease, such as sarcoid, chronic obstructive pulmonary disease, or pneumonia, ectopic tumor production or paraneoplastic syndrome, such as small cell lung carcinoma, and drugs including antipsychotics, antidepressants, and NSAIDs. On physical exam, patients are typically euvolemic. Diagnosis is made with serum osmolality less than 280 mosm/kg, indicating hypotonicity. Urine osmolality greater than 100 mosm/kg in the setting of serum hypoosmolarity without a physiologic reason for increased ADH, such as congestive heart failure. Cirrhosis, or hypovolemia, and a urinary sodium level often greater than or equal to 40 milliequivalent L. Treatment requires exploration of and addressing the underlying cause. The best initial treatment is restriction of fluid. Persistent or symptomatic hyponatremia less than 120 milliequivalent L is treated with intravenous hypertonic saline therapy. Severe SIADH can be managed with ADH antagonists such as tolvaptan or conivaptan. Chronic SIADH may be treated with dimeclocycline. Fluid restriction is the cornerstone of SIAD treatment, and hyponatremia should be corrected slowly to prevent osmotic demyelination syndrome. Adrenal gland disorders involve abnormalities of the adrenal cortex or medulla. The adrenal glands are located on the superior surface of each kidney and consist of an outer cortex and an inner medulla, surrounded by a capsule. The adrenal cortex has 3 distinct histologic zones, each producing specific hormones under different regulatory control. The outermost zona glomerulosa is primarily regulated by angiotensin II and produces mineralocorticoids, mainly aldosterone. The middle zona fasciculata is regulated by ACTH and CRH and produces glucocorticoids, predominantly cortisol. The innermost zona reticularis, also under the regulation of ACTH and CRH, produces adrenal androgens, including dihydroepiandrosterone, DHEA. The adrenal medulla is composed of chromaffin cells derived from neural crest tissue and is stimulated by preganglionic sympathetic fibers. The medulla produces catecholamines, mainly epinephrine and norepinephrine, which are secreted in response to sympathetic activation. A key fact to remember is that dihydroepiandrosterone sulfate, DHEAS, is produced only by the adrenal gland. Adrenal insufficiency refers to inadequate production of adrenal hormones, including glucocorticoids and sometimes mineralocorticoids. It may be primary, secondary, or tertiary in etiology. Primary adrenal insufficiency, most commonly Addison disease in the United States, results from autoimmune adrenal cortical destruction. Other causes include infections such as tuberculosis, HIV, and histoplasmosis, congenital enzyme deficiencies, and adrenal hemorrhage such as Waterhouse-Friderichsen syndrome for Neisseria meningitidis. Secondary adrenal insufficiency is due to decreased ACTH production by the pituitary gland, while tertiary adrenal insufficiency is due to decreased corticotropin-releasing hormone production by the hypothalamus. The most common cause of secondary and tertiary adrenal insufficiency is cessation of long-term glucocorticoid therapy, especially when taken at higher doses and for longer duration. A key fact is that primary adrenal insufficiency is associated with increased skin pigmentation, decreased glucocorticoids, and decreased mineralocorticoids. Secondary adrenal insufficiency, in contrast, is associated only with decreased glucocorticoids and does not present with skin pigmentation or hyperkalemia. Most symptoms of adrenal insufficiency are nonspecific and include weakness, fatigue, anorexia with weight loss, and gastrointestinal complaints such as nausea and abdominal pain. Hyperpigmentation occurs only in primary adrenal insufficiency because of increased ACTH secretion. Anion-gap metabolic acidosis is also seen in primary adrenal insufficiency due to decreased aldosterone. Hyperpigmentation is absent in secondary and tertiary adrenal insufficiency due to reduced ACTH secretion. Acute adrenal crisis, such as when long-term steroids are suddenly stopped, presents with hypotension, confusion, and coma. The mnemonic for the 4 S's of adrenal crisis management is SALT, referring to 0.9% saline; steroids, referring to intravenous hydrocortisone; support, including hemodynamic and glucose stabilization; and search, to identify and treat the underlying illness. Diagnosis is based on laboratory findings, which may include hypoglycemia and electrolyte imbalances. In adrenal insufficiency, laboratory findings differ between primary and secondary or tertiary causes. In primary adrenal insufficiency, there is decreased cortisol and decreased aldosterone production, leading to elevated ACTH levels, hyponatremia, and marked hyperkalemia. In contrast, secondary and tertiary adrenal insufficiency show decreased cortisol with normal aldosterone levels, since aldosterone secretion is primarily regulated by the renin-angiotensin system and not ACTH. ACTH levels are low, serum sodium may be normal or mildly decreased, and potassium levels are typically normal. Diagnosis of adrenal insufficiency involves measurement of 8 AM plasma cortisol levels and ACTH levels. An 8 AM plasma cortisol level of less than 3 μg/dL, in the absence of exogenous glucocorticoid administration, is diagnostic of adrenal insufficiency. Diagnostic algorithm for adrenal insufficiency begins with concern for adrenal insufficiency. The first step is to check 8 AM cortisol. If cortisol levels are normal, there is no adrenal insufficiency. If the results are indeterminate, then a concentropin stimulation test with 30-minute cortisol levels is performed. If cortisol levels are normal after stimulation, there is no adrenal insufficiency. If there is a minimal cortisol response and cortisol levels remain low, adrenal insufficiency is confirmed. The next step is to measure ACTH. Low ACTH levels indicate secondary or tertiary adrenal insufficiency, while elevated ACTH levels indicate primary adrenal insufficiency. If morning cortisol levels are non-diagnostic, the test of choice is the synthetic ACTH stimulation test, also known as the concentropin test. Failure of cortisol to rise above 20 μg/dL following ACTH administration confirms the diagnosis. Key fact: Do not delay the administration of steroids for diagnostic testing in a patient with suspected adrenal insufficiency. Treatment for adrenal insufficiency depends on the type. In primary adrenal insufficiency, both glucocorticoid and mineralocorticoid replacement are required. In secondary or tertiary adrenal insufficiency, only glucocorticoid replacement is necessary since mineralocorticoid production is not ACTH dependent. In cases of acute adrenal crisis, management includes intravenous steroids, correction of electrolyte abnormalities, administration of 50% dextrose to correct hypoglycemia, and initiation of aggressive volume resuscitation. Prevention strategies include increasing steroid doses during periods of stress, such as major surgery, trauma, or infection. In patients on chronic steroid therapy, taper steroids slowly to prevent the development of secondary or tertiary adrenal insufficiency. PHEOCHROMOCYTOMA is a tumor of chromaffin tissue that secretes catecholamines and is found either in the adrenal medulla or in extraadrenal sites. It is most commonly associated with multiple endocrine neoplasia type 2, MEN2A, and MEN type 2B, MEN2B. Mnemonic. The pheochromocytoma rule of tens. 10% are extraadrenal, 10% are bilateral, 10% are malignant, 10% occur in children, and more than 25% are familial in adults. History and physical examination. Pheochromocytoma presents with paroxysmal tachycardia, palpitations, chest pain, diaphoresis, episodic or persistent hypertension, headache, tremor, anxiety, pallor, and weight loss. It may be misdiagnosed as anxiety or panic disorder. Obtaining a family history can rule out genetic causes of pheochromocytoma, such as MEN2A, MEN2B, von Hippel-Lindau disease, and neurofibromatosis type 1. Diagnosis. The best initial test is an increase in 24-hour urine metanephrines and catecholamines or plasma fractionated metanephrines. Helpful laboratory findings include hyperglycemia with or without polycythemia if erythropoietin is secreted. Imaging studies, which should only be performed after laboratory confirmation, include CT or MRI of the adrenal glands. A nuclear metabenzoguanidine (MIBEG) scan can be used to localize extraadrenal lesions and metastatic disease. Mnemonic. The 5 P's of pheochromocytoma are pressure, blood pressure, pain, headache, perspiration, palpitations, and pallor. Treatment. The treatment is surgical resection. Preoperatively, the first step is alpha-adrenergic blockade with phenoxybenzamine to control hypertension, followed by beta blockade to control tachycardia. Beta blockade should never be given first, as unopposed alpha-adrenergic mediated vasoconstriction can lead to severe hypertension. If bilateral adrenalectomy is performed, glucocorticoids are given to prevent acute adrenal insufficiency. Key fact: in pheochromocytoma, administration of alpha blockers should occur before beta blockers to prevent hypertensive crisis. Cushing's syndrome. Cushing's syndrome is caused by elevated serum cortisol levels, and it most frequently develops secondary to prolonged treatment with exogenous corticosteroids. The most common endogenous cause is hypersecretion of ACTH from a pituitary adenoma, known as Cushing disease. Other endogenous causes include excess adrenal secretion of cortisol, such as bilateral adrenal hyperplasia, adrenal adenoma, adrenal cancer, and ectopic ACTH production from an occult neoplasm, such as carcinoid tumor, medullary thyroid cancer, or small cell lung cancer. Key fact: Cushing syndrome, too much cortisol. Cushing disease, too much cortisol from an ACTH-producing pituitary adenoma. History physical examination. Classic signs and symptoms of Cushing syndrome include pituitary tumor, emotional disturbances, buffalo hump, hirsutism, moon face, cardiac hypertrophy, thin wrinkled skin, obesity, abdominal striae, muscle weakness, osteoporosis, insulin resistance, adrenal tumor or hyperplasia, hypokalemia, hypertension, purpura, skin ulcers with poor healing, amenorrhea, and erectile dysfunction. Mnemonic: Cushing syndrome symptoms, Cushingoid, cataracts, ulcers, skin changes such as striae, bruising, thinning, or ulcers, hirsutism and hypertension, infections, necrosis of the femur head, glycosuria, obesity and osteoporosis, immunosuppression, diabetes. Diagnosis: Clinical suspicion of Cushing syndrome should be evaluated by performing either a 24-hour urinary free cortisol test, a 1 mg overnight dexamethasone suppression test of plasma cortisol, or a late-night salivary cortisol test. If results are normal, not Cushing syndrome. If results are abnormal, Cushing syndrome is probable, and the next step is to measure plasma ACTH. If ACTH is low or suppressed, this suggests a probable adrenal tumor and should be confirmed with an adrenal CT scan. If ACTH is high or normal, this indicates ACTH-dependent Cushing syndrome and requires further evaluation. An MRI of the pituitary is performed. If an adenoma greater than 6 mm is found, the diagnosis is Cushing disease. If no adenoma or a lesion smaller than 6 mm is seen, inferior petrosal sinus sampling is performed. A central to peripheral ACTH gradient confirms Cushing disease, while the absence of a gradient suggests ectopic ACTH-dependent Cushing syndrome. In the evaluation of Cushing syndrome, a 24-hour urinary free cortisol is elevated in Cushing disease caused by pituitary hypersecretion, in exogenous steroid use, in ectopic ACTH secretion, and in adrenal cortisol hypersecretion. Salivary cortisol is also elevated in Cushing disease due to pituitary hypersecretion, in exogenous steroid use, in ectopic ACTH secretion, and in adrenal cortisol hypersecretion. ACTH levels vary depending on the cause. In Cushing disease from pituitary hypersecretion, ACTH is elevated. In exogenous steroid use, ACTH is decreased. In ectopic ACTH secretion, ACTH is elevated, while in adrenal cortisol hypersecretion, ACTH is decreased. The dexamethasone suppression test is then used to help distinguish causes. In the low-dose dexamethasone suppression test, cortisol remains elevated in Cushing disease due to pituitary hypersecretion, in ectopic ACTH secretion, and in adrenal cortisol hypersecretion, while it is not applicable in exogenous steroid use. In the high-dose dexamethasone suppression test, cortisol levels decrease in Cushing disease from pituitary hypersecretion, but remain elevated in ectopic ACTH secretion and adrenal cortisol hypersecretion, while it is not applicable in exogenous steroid use. A dexamethasone suppression test is not required once the diagnosis of ACTH-independent Cushing syndrome is established. Key fact: in Cushing disease, cortisol secretion remains elevated with a low-dose, 1 mg, dexamethasone test, but is suppressed with a high-dose, 8 mg, dexamethasone test. Treatment: for exogenous Cushing syndrome, the management is gradual withdrawal and stoppage of glucocorticoids. For endogenous Cushing syndrome, the treatment is surgical resection of the source, whether pituitary, adrenal, or ectopic neoplasm. Permanent hormone replacement therapy may be required to correct deficiencies after treatment or resection of the primary lesion. Hyperaldosteronism. Hyperaldosteronism results from excessive secretion of aldosterone from the zona glomerulosa of the adrenal cortex. It is usually caused by bilateral adrenocortical hyperplasia, 60%, 70%, but can also result from unilateral adrenal adenoma, Conn syndrome. History: P. presents with hypertension, headache, polyuria, muscle weakness caused by hypokalemia, and constipation or paralytic ileus, particularly if hypokalemia is severe. Consider hyperaldosteronism in younger adults who are diagnosed with hypertension without risk factors or a family history of hypertension. Diagnosis. Lab tests can confirm primary hyperaldosteronism with increased urinary aldosterone after oral sodium loading or saline infusion test, which shows failure to suppress aldosterone secretion. Findings include hypokalemia, metabolic alkalosis, hypomagnesemia, hyperaldosteronism, and an elevated aldosteronoplasma-renin activity ratio, usually greater than 30. Imaging should only be done after labs. CT or MRI may reveal an adrenal mass. Adrenal venous sampling, which will show elevated aldosterone, may be needed to localize the adenoma or to confirm bilateral adrenal hyperplasia. Treatment. For unilateral adenoma, surgical resection is indicated after correction of blood pressure and potassium. For bilateral hyperplasia, treatment involves an aldosterone receptor antagonist, such as spironolactone, with a switch to eplerenone if side effects occur. Clinical case. An asymptomatic 36-year-old woman presents with a 2 centimeters thyroid mass. TFTs are unremarkable, but FNA reveals medullary carcinoma. Total thyroidectomy with thyroid hormone replacement is recommended. What are the most important screening tests to perform prior to surgery? The most important screening tests to perform are vanillomandelic acid, VMA, and metanephrines. Medullary carcinoma of the thyroid is associated with MIN type 2A2B, an autosomal dominant condition that predisposes patients not only to medullary carcinoma, but also to pheochromocytomas. Screening for pheochromocytoma with urine VMA and metanephrines prior to surgery can prevent potentially life-threatening hypertensive crises during thyroidectomy. Congenital adrenal hyperplasia. Congenital adrenal hyperplasia, CH, refers to genetic enzyme defects that impair cortisol synthesis, resulting in glucocorticoid insufficiency and buildup of precursors. Most cases are caused by 21-hydroxylase deficiency, 95% autosomal recessive, but other causes include 11-hydroxylase and 17-hydroxylase deficiencies. Mnemonic. For CH, if the deficient enzyme begins with 1, 11, and 17, mineralocorticoid activity is high. If it ends with 1, 11, and 21, androgen activity is high. Congenital adrenal hyperplasia, enzyme deficiencies. 17. Alpha-hydroxylase deficiency. In this condition, mineralocorticoid levels are increased, cortisol levels are decreased, and sex hormone levels are decreased. Blood pressure is elevated, and potassium levels are low. Laboratory testing shows decreased androstenedione. The clinical presentation includes pseudohermaphroditism in individuals with XY chromosomes, leading to ambiguous genitalia and undescended testes. In individuals with XX chromosomes, there is a lack of secondary sexual development. 21-hydroxylase deficiency. This is the most common enzyme deficiency in congenital adrenal hyperplasia. In this condition, mineralocorticoid levels are decreased, cortisol levels are decreased, and sex hormone levels are increased. Blood pressure is low, and potassium levels are elevated. Laboratory testing reveals increased renin activity and increased 17-hydroxyprogesterone, along with decreased sodium and decreased chloride. Clinically, it presents in infancy with salt wasting or in childhood with precocious puberty. Individuals with XX chromosomes often present with virilization. 11. Beta-hydroxylase deficiency. In this condition, aldosterone levels are decreased, but there is an increase in 11-deoxycorticosterone, which has mineralocorticoid activity and results in elevated blood pressure. Cortisol levels are decreased, and sex hormone levels are increased. Blood pressure is elevated, and potassium levels are decreased. Laboratory testing shows decreased renin activity. Clinically, individuals with XX chromosomes present with virilization to increased. All congenital adrenal enzyme deficiencies are characterized by enlargement of both adrenal glands, which occurs due to increased ACTH stimulation caused by decreased cortisol. Diagnosis. The diagnosis of congenital adrenal hyperplasia is based on laboratory tests. Electrolyte abnormalities are common, and in severe cases, mineralocorticoid deficiency may lead to life-threatening salt wasting. An elevated serum 17-hydroxyprogesterone level is diagnostic of 21-hydroxylase deficiency. Treatment. Management involves immediate fluid resuscitation and salt repletion. Cortisol should be administered to suppress ACTH and reduce adrenal androgen production. Fludrocortisone is appropriate in cases of severe 21-hydroxylase deficiency. Surgical correction of ambiguous genitalia may also be considered when necessary. For information regarding the diagnosis and treatment of late-onset congenital adrenal hyperplasia, refer to the gynecology section. Key fact: congenital aromatase deficiency presents in a way that is similar to congenital adrenal hyperplasia in female newborns, with external virilization and ambiguous external genitalia. However, unlike CH, patients with aromatase deficiency do not have electrolyte disturbances or blood pressure abnormalities. Multiple endocrine neoplasias, men. Multiple endocrine neoplasias are a family of tumor syndromes inherited in an autosomal dominant pattern. Men type 1, formerly called Wermer syndrome. This type is characterized by pancreatic islet cell tumors, parathyroid adenomas, and pituitary adenomas. The pancreatic islet cell tumors include gastrinomas, which cause Zollinger-Ellison syndrome, insulinomas, which present with recurrent hypoglycemia along with elevated insulin and C-peptide levels, VI-PUMIS, which are associated with watery diarrhea, hypokalemia, and hypochlorhydria, glucagenomas, which may present with new-onset diabetes and necrolytic migratory erythema. Men type 2A, formerly called Sippel syndrome. This type is characterized by medullary carcinoma of the thyroid, PHEOCHROMOCYTOMA, and parathyroid hyperplasia or adenomas. It is caused by mutations in the RET proto-oncogene. Men type 2B. This type is characterized by medullary carcinoma of the thyroid, pheochromocytoma, oral and intestinal ganglioneuromatosis, such as mucosal neuromas, and a marfanoid habitus. Like type 2, it is also caused by mutations in the RET proto-oncogene.